So today I would like to talk about our minimally invasive approach to surgical management of HCC, and I would like to talk about three topics. One is really briefly touch on the outcomes, and then talk a little bit about the technique, and then move on to the most interesting topic, at least for me, which is indications in the era of minimally invasive surgery. Now, we just published a paper looking at the National Cancer Database and did a propensity score matched analysis of patients who underwent an open or minimally invasive resection for HCC. You were able to find about 1,000 or match about 1,000 patients in each group. And as you can see, the long-term outcomes were really, really similar, which based on the data that we already heard from Dr. Geller was kind of expected. However, interestingly, when we looked at the 90-day mortality, we found a significant advantage for patients who underwent a minimally invasive resection. And also we found that the risk of dying within 90 days after surgery was significantly higher in patients who underwent a minimally invasive resection at a non-academic center. The other interesting finding was the results on the risk of a positive margin. Here we found a higher rate of positive margins in patients who had a minimally invasive operation. And again, if you had the operation done at an academic center, your risk of having a positive margin was lower. So, I think looking at the outcomes, it's important not just to look at the long-term outcomes, but really look into the subgroups. And I think there is still some more work to do to figure out the advantages of laparoscopic or minimally invasive surgery for HCC and how we can really offer it to a broad range of patients, across different kinds of institutions. Now, as I said, I would like to talk about the technique of minimally invasive surgery for HCC and really briefly talk about the biology of HCC and the way it metastasizes. We already heard an excellent talk on anatomic versus non-anatomic surgery for HCC, and I just really briefly wanted to touch on the way of metastatic spread in HCC, which happens along the portal branches. And this is why if you do a non-anatomic operation, you may end up leaving disseminated tumor cells behind, as opposed to a anatomic operation where you will more likely be able to remove all the tumor together with the disseminated tumor cells. So in my practice, I prefer to do an anatomic resection whenever it's possible based on the patient's liver function. Now, how do I know the borders of a segment within the liver? I just wanted to show you a case of a patient with liver cirrhosis and an HCC in segment 8. You can see the tumor is really just next to the segment 8 pedicle, and we were planning on doing an open segment 8 resection. For open cases, I prefer to do the direct injection method using a dye, methylene blue, for example, that I inject into the portal pedicle using intraoperative ultrasound. And as you can see, segment 8 is highlighted, and then you can do the operation and do an anatomic resection of the segment. Now, how do I do it in minimally invasive surgery? There, it can really be difficult to do the direct injection methods. So what I rather like to do is to do the indirect or reversed staining method by clamping a pedicle and then looking for the demarcation or giving ICG. This I can show you again for a patient with a lesion in segment 8. This is the lesion that we are aiming to resect with an anatomic segment 8 resection using a laparoscopic approach. The operation starts with the hilar dissection, looking for the right anterior pedicle and dissecting out the segment 8 pedicle using the laparoscopic approach. Once I have identified segment 8 pedicle, I use a bulldog clamp to clamp it, and you can see a nice demarcation of segment 8. You can, of course, use ICG to emphasize the demarcation, and this is also helping you during the further course of parenchymal transection. Now, if you proceed with the operation, you will then again find the bulldog clamp that you placed during hilar dissection, and this way you will be able to take down the segment 8 pedicle and complete the anatomic resection. Now, I would like to proceed and talk about indication. And as I said, this is for me really the game changer when it comes to the use of minimally invasive surgery in HCC. We talked already, or Dr. Pollack already talked about the BCLC guidelines, and it was just updated, expanding the indications for resection to patients with a single or multiple nodules, each less than 3 centimeters in diameter. However, if you look at the further indications for surgery, you will see that according to the BCLC guidelines, at least at the current, in its current or most updated version, you can only, or you're only allowed to remove tumors in patients with normal portal pressure or normal bilirubin levels. Now, if you look at the author affiliations, you will really very quickly see why the indications are so restricted, because it's only one person represented in the authors group that is a surgeon. So we are not really well represented in the guidelines, and this is why I think we really need to work on extending the indications. And I will talk about a couple of indications that I think are crucial to extend surgery or offer surgery to our patients. Now, really the group that I think benefits the most from laparoscopic or robotic resection is patients with cirrhosis, which is the majority of patients. And why is it that patients with cirrhosis benefit more than patients without? Now, first of all, the trauma is less. You cause less compression and mobilization of the liver, and also in most cases during laparoscopic surgery, you do not have to take down the round ligament, preserving collateral blood flow and reducing the risk of post-hepatectomy liver failure or ascites. And this has been known for quite a while. This is data from a meta-analysis that showed significantly less ascites and lower incidence of post-hepatectomy liver failure in patients who had a minimally invasive operation as opposed to an open operation in the context of cirrhosis. This recent study by Roberto Troisi has already been shown. This is, a multi-center study on patients with child B cirrhosis. And again, the data is, similar. You have lower 90-day morbidity and especially less major morbidity, and also a shorter hospital stay, highlighting the advantages of minimally invasive surgery and sort of supporting the idea of offering surgery to these patients, even though it's not recommended in the current guidelines. The other indication that I think is emerging is patients who have progressive disease on sort of palliative treatments. This is a patient with a HCC, with alcoholic liver disease and HCC. He was treated with TACE, and the first couple of sessions he had a good response, but then the interventional radiologists said that a further TACE is not possible, and he was then presented to us for evaluation of surgery. Now, you can see the tumor in a patient with multiple TACE sessions. This is really not the candidate that you would ask for to do an operation. We still decided to take him to the operating room and did a central hepatectomy, laparoscopic central hepatectomy. And as you can see, the patient had an uneventful post-operative course, and we were able to do a resection with negative margins. And just to show you the incisions, you can tell that the trauma in this patient, or abdominal wall trauma, is very limited, and the patient was able to leave the hospital without any complications. And this is his post-op scan. See his AFP dropped, and the patient had an uneventful further course. So this is just a case to highlight a possible new indication for surgery, patients who progress on previous treatments. We have now operated on 7 of these patients. Just to show you the outcomes, I can just summarize it and tell you that the risk that you have major complications or even mortality in these patients is still very low. So I think this idea of offering surgery to patients who progress on palliative treatments needs to be further evaluated in future studies. The other concept that I would like to briefly touch upon is the concept of R1 or expected R1 resections. This is work really pioneered by Dr. Troisi from Milan. The idea is that you can have 2 types of an R1 resection. One is R1 at the site of major vasculature, and the other one is an R1 resection at the parenchymal site. And biologically, this is really different, as you have the vessels as a natural or biological border, as opposed to no border in the R1 parenchyma group. And in theory, the R1 vascular resections are oncologically equivalent to an R0 resection, whereas the R1 parenchyma resections are inferior to an R0 resection. And Guido has shown this for HCC patients and also for patients with colorectal liver metastasis. These patients have a long-term outcome which is equivalent to an R0 resection. For patients with cholangiocarcinoma, the outcomes are less favorable, but still better than no resection. So there's still more work to be done on cholangiocarcinoma, but at least at this stage, we can say that for HCC patients, it is probably justified to take the tumor out with an R1 resection if the R1 site is at the site of major vasculature. And I always tell Guido that, for me, he's a Superman because he really broke with the dogma that you have to take major vasculature and maybe, do a major operation in patients with an HCC that touches on, a major pedicle or the hepatic veins. And I will show you a case that this can be done laparoscopically. So this is a patient with an HCC in segment 8. Patient has autoimmune hepatitis and portal hypertension. So you would not like to do a major or extended right hepatectomy in this patient. The tumor is located just between the middle and the right hepatic vein at the hepatic outflow. And just to show you our approach, this was done laparoscopically, using the Thunderbeat device. We usually use an high pneumoperitoneum to keep intraoperative blood loss low, which is also very important in these patients with advanced liver disease. And you will see that even in patients, with tumors located adjacent or, tumors touching the hepatic veins, you can still safely remove them using the minimally invasive approach, even though you will end up having an R1 resection, which was also the case for this patient. However, the tumor is taken out, and this patient also had an uneventful postoperative course. I would like to summarize my talk. I showed you that long-term outcomes of minimally invasive surgery for HCC are comparable to those of open surgery. However, the perioperative mortality seems to be better, especially in patients with cirrhosis. For the operative technique, I would strongly favor an anatomic resection if this is possible based on the patient's liver function, and based on the advantages of minimally invasive surgery. I think the indications for surgery need to be expanded, and I think a collaborative effort is needed from us as surgeons to really change the guidelines in a way that allows us to offer these operations to our patients. Thank you very much.